And so I'll go back to Tom, just kind of how should we be thinking about maintenance? Obviously, it kind of depends on what you give the patient up initially, correct?
Yeah. So the patients who the non-squamous patient population who I start on carboplatin, paclitaxel, bevacizumab, I tend to use the bevacizumab maintenance strategy straight out of the ECOG 4599 trial. The patients who I do carboplatin, pemetrexed, I tend to do the pemetrexed maintenance as a basis. I tend to use maintenance in people who are tolerating the therapy well and have a good performance status, and then still want to get therapy, because sometimes we do have that conversation after 4 cycles and the patient says, I want to be away for the summer, I don't want to have to worry about this, and I think a treatment break is still a viable alternative, particularly if it integrates with the patient's goals.
Okay. Heather, any thoughts?
I just want to mention the ECOG 5508 study, which is hopefully going to finish up accrual here in the next 6 months or so.
And that study is?
That is the study looking at carboplatin, paclitaxel, bevacizumab, and then looking at a maintenance question. So for non-progressors after 4 cycles, they're randomized to stay on the bevacizumab, the 4599 regimen, to stop it, and to go on to pemetrexed. So the first trial really questioning that continuation of bev, which has always been once done, or the third arm is the combination of both. And I think that's absolutely critical question that's being asked there as far as maintenance in the setting of carboplatin, paclitaxel, bev. It's not helping us with the continuation maintenance question with pemetrexed, but for patients started on paclitaxel regimen, it can answer that. So it's a really important study, and we are participating in that actively.
Yeah, it's a great, I think it's a great study, very pertinent to practice nowadays, although one of the things that I wanted to ask the panel is, it sounds like probably in the minority of patients you're using carboplatin, pemetrexed, bevacizumab, but let's say you do. What do you do for maintenance?
When I use that regimen, I do give both pemetrexed and bevacizumab
TwoDrug
maintenance. Yes.
Okay.
The avapearl data, though the overall survival endpoint wasn't hit, it was awfully close. And so I do tend to keep going with both drugs when they're tolerated.
I use both.
Okay. Roy?
I'd agree with that. I don't often give the 3 drugs, but if I did, I would use both as maintenance.
Okay.
I'd follow the Patel, the 2-drug maintenance. I think Heather brings up a good point about ECOG 5508, because it will answer the question of 2-drug maintenance versus 1-drug maintenance pretty clearly for us.
And Tom, you kind of alluded to this issue. Is maintenance the standard of care?
For the right patients, the standard of care. I think there are patients who are very worn out and have had some complications from platinum doublet who do need a break in terms of quality of life and improving their performance status. And I think that you're on good ground to give a break in those patients.
So I may be in the minority, Mark, but I actually like to do maintenance in squamous cell, because previously we really didn't have very good options for squam. So I would do cisdocetaxel or carbotaxel for 4 cycles and then do switch maintenance over to erlotinib. Now that may change as we've got all the new agents that we're going to talk about shortly, but that has been something that I've done.
And I know that's frequently done also with the carbo-gem regimen, is that people continue the gem. And we do actually have some data on gem kind of continuation maintenance from the Pearl trial and the older trial that I can't remember the author.
Brodowitz.
That's right. Heather?
I'm a fan of continuation maintenance with GEM, even in squames, but I know that's controversial. There's, I think, a really important study ongoing with nab-paclitaxel that's asking a continuation maintenance includes squames. And so I'm looking at that and waiting to see that data. I think that will be very important also.
But I think Tom's point is a good point in that one of the fears I have about maintenance is keeping people on therapy forever. There's clearly cumulative toxicity from the maintenance regimens in patients who have good control of their disease and who are reliable and will follow up. I do think a treatment break can be incredibly therapeutic.
Right.
And people have life events. We aren't curing these people, right? They have life events they want to take time off for and stuff like this. So they often feel better, 6 weeks off of maintenance. And that can be quite good for patients.
Right.
So.
I do find my intervals of the chemo tend to spread out a little bit over time as the maintenance goes on.
Let's kind of transition to a few more details about bevacizumab in terms of that. Is any question in anyone's mind about the dose of maintenance? Are people Are people, actually two questions, dose and I guess the concept. Do people believe that bevacizumab is a good maintenance drug?
I think the dose is 15 milligrams per kilogram every 3 weeks, and that's been my practice. I think there's always been some questions about how much incremental benefit you get from maintenance bevacizumab. I think it was done as part of the trial, so I've tended to continue the way it worked in the trial. But I think,
So in East Asia and Europe, they're going to argue that 7.5 is a perfectly acceptable dose.
Right.
I mean, obviously here in the U.S., we get it covered under the 15. But they, report that their efficacy is, the same, and the toxicity is like pretty much identical. So I think that we don't really know. It's sort of a non-issue for us in terms of dosing here in the U.S. because mostly we have to get, for coverage and reimbursement, we do 15.
And I think the ECOG 5508 will give us a little bit of hint about that, although I think the ship has sailed on doing a real bevacizumab maintenance trial. I don't think we'll ever do that sort of thing. I think the closest we'll come is
I think
5508.
5508 is answering the question. I think one of the other questions that comes up is not just maintenance, but into progression. We have data from colorectal cancer that patients who are on a bevacizumab regimen who then stay on it at the point of progression when the chemo switched actually do better than people who stop it at the time that they switch to chemotherapy. And there is an ongoing study looking at that question in lung cancer patients. It's sort of the continuation beyond progression.
So what do you do in your practice now?
I don't give it, but
Does anyone continue it with second-line therapy?
No, especially since we have the new options with ramucirumab.
That's a perfect transition.
Don't think we need to.
So